So I'm here to talk to everyone about how much surgery do I need for melanoma? And it's a critical question because I'm usually the starting point for many of you on this journey. So my name is Maris Jones, and I'm a surgical oncologist at Kaiser Permanente, Santa Clara. So an overview of my talk today. First, I'll start with a little bit of history in terms of the surgical treatment of melanoma, which becomes critical in terms of talking about other aspects of surgical melanoma care. Then I'll move on to discuss the mainstay of treatment for melanoma surgically, which is wide excision and what margins we need after excision of your melanoma. And then I'll move on to a discussion of sentinel lymph node biopsy. And then a really pertinent topic, especially now, since recent publications, a discussion of axillary lymph node dissection and when that becomes necessary. I have nothing to disclose. So a bit of history. Melanoma was first described in the Western literature by John Hunter in 1787. And it was described as well by some of his contemporaries, including René Laennec, as melanosis or cancer noir. And it took some time for some of these scientists and early physicians to connect the pigmented nodal disease with melanoma moles. And William Norris was one of the first to describe melanoma and this constellation of symptoms and findings in the English literature in 1820. And he was really the first to correlate these moles as being associated into developing into melanoma later on. Herbert Snow in 1822 was one of the first to advocate for complete lymph node removal as a therapeutic option for patients with this disease. And I'll discuss him a little bit later because it becomes really critical in terms of what we do today. W. Sampson Handley was an English surgeon who published extensively on melanoma as well, in addition to some other tumor types. And he was one of the first to really study and document the connection between the primary tumor, the lymphatics, and in-transit and nodal melanoma metastases. And you can see here in one of his illustrations, he really documented and depicted this connection between the primary melanoma tumor and its extension into the subcutaneous tissue via lymphatic channels, and how that led then to the draining nodal basin. As an extension of that, Herbert Snow, who I mentioned a little bit earlier, in 1892, published his seminal work, Melanotic Cancerous Disease, and he put it all together, really, and linked these moles that spread via lymphatic channels to the regional nodal basin, and he advocated for not only wide excision, but also elective lymph node dissection for all of these patients. And you can see here his publication as well as his operating room staff in the late 1800s. So why is this all important other than just a nice history lesson, right? Because the link between lymphatics and melanoma is critical for everything we do today, but especially for the surgical care of melanoma. It impacts the margins that we have to take for differing thicknesses of melanomas, and it also impacts the extent of lymphatic surgery that we have to think about doing. So that makes a nice segue into a discussion on margins for melanoma. And as many of you likely know, the primary therapy for melanoma is wide local excision. And you can see here the skin and the dermis and epidermis are not the only areas of interest, right? We want to make sure that we excise the skin, epidermis, subcutaneous tissue all the way to the layer just above the muscle or the fascia. And that will allow wide excision of not just the melanoma mole, but also those lymphatic channels. Those lymphatic channels, as you can see in figure 4, spread throughout the body and can lead to satellite recurrences, not just in the scar, but also can lead to some of those melanoma cells traveling and leading to what we call in-transit recurrences. So wide excision of everything, the dermis, the epidermis, the subcutaneous tissues and lymphatic channels is critical as a part of wide excision. So how do we know how much to take? Invasive melanoma is measured by Breslow thickness, as many of you most likely know, and this measures how deeply the melanoma has penetrated into the skin in millimeters. And that impacts the T stage, or the staging of your melanoma. So we consider thin melanomas, intermediate melanomas, and thick melanomas to be treated differently based on how deep they extend into the skin. And why does this matter? Well, many of the prospective trials that looked at what margin is appropriate to decrease recurrence for melanoma were based on the Breslow thickness, which varies from 1 to 4 millimeters for our categories of invasive melanoma. In situ melanomas as well have been studied. And so for in situ melanomas, we typically think a surgical margin of about 1/2 centimeter to 1 centimeter, depending upon which paper you read, is adequate. For thin invasive melanomas, so less than or equal to 1 millimeter in Breslow thickness, we think that 1 centimeter is acceptable based on randomized prospective trial data. For melanomas that are 1 to 2 millimeters in Breslow depth, 1 to 2 centimeters is an appropriate surgical margin around the primary tumor, depending upon where they are in the body. And then for melanomas that are 2 to 4, or these sort of intermediate thickness melanomas, 2 centimeter margin is appropriate, as well as for thick melanomas greater than 4 millimeters. Again, a 2 centimeter margin is appropriate based on these multi-center randomized trials. So how do we accomplish this surgically, right? It seems like a pretty big area to have to remove. And you can see here in the image, the mole is in the center, and the sphere around it would be the appropriate margin width that we would measure. The convention is to measure the margin around either the scar or the existing pigment that's left over after the biopsy. And from there, we would measure the margin and make a circle around the tumor. That would be what we have to remove to excise an adequate amount of skin, subcutaneous tissue, and lymphatics. Why then do many patients end up with a much longer incision, right? That's so that we can create a smooth linear scar that's much easier to surveil and look for recurrences in the site. They close nicer, they just look nicer, right? So we convert that sphere into an ellipse in about a 3-to-1 ratio to get everything to close nicely and smoothly. So that's really the principle of surgical excision, and sometimes, depending upon where these are in the body, we'll need to rotate a little normal skin around to get things to close down nicely and smoothly. Sometimes patients will also need skin grafts or other rotational flaps and assistance from plastic surgeons to close these nicely. So it becomes a challenging decision-making process when we're looking at the location of the mole, what residual pigment remains, and how we're going to close these. It's not always as simple as just an ellipse, right? So that's margins. The next phase in treatment of melanoma, depending upon the thickness, right, for anything typically greater than 0.8 or certain high risks, is sentinel lymph node biopsy, which is an invaluable staging tool. So we talked about in the beginning, in the bad old days, elective lymph node dissections where we removed every lymph node in the regional basin was the standard. And as you might imagine, this was fairly disfiguring. They were big surgeries, and they led to lymphedema, or swelling of the extremity or portion of the body, because we removed so many of the lymphatic channels. And lymphedema can be permanent and disfiguring. It can require physical therapy, compression garments, and many follow-up treatments, and it can be painful. And so many surgeons and scientists were looking for alternatives to this morbid procedure. And now, after the work of Donald Morton and some other surgeons, sentinel lymph node biopsy is a staging procedure where we don't have to remove all the lymph nodes in the regional basin. And this was reported initially in the 90s, but the final trial report was published by Dr. Morton and the MSTL-I trial group in 2014. And this trial really changed practice for how we treat melanoma. So what did the trial show us? Instead of removing all of the lymph nodes in the body, we could do a targeted or so-called sentinel lymph node biopsy and identify if the tumor had spread, and instead of having to remove all of the lymph nodes in that basin. So this trial showed that sentinel lymph node status, if that sentinel lymph node was positive, it was the single most important predictive value other than Breslow thickness, but even more predictive in terms of if a patient would have recurrence from their melanoma or if they would die from their melanoma. So it became a critical piece of information that changed the way we treat this disease. So what is it, and when do we do it? So for patients with an invasive melanoma greater than 0.8 millimeters in Breslow thickness, or for certain other less thick but high-risk histologies, you would have the opportunity to discuss this procedure with your surgeon. In situ melanomas and many thin melanomas, however, do not require this because they are at very low to zero risk of spreading to the nodal basin. So the procedure is initiated before the wide excision, and it would be done in the same operating time. And the patient would have a radioactive tracer injected into the tumor, and then while the patient's asleep, you'd have a blue dye injected into the tumor. And then you look for any lymphatics and lymph nodes that are blue or radioactive or both. And you can see here, these are some surgical photos of the procedure, and you can see the blue dye trickling through the lymphatic channels on the way to the node, and then a hint of a blue node there in the second photo. And those will be the nodes that I would look for, remove, send to the lab. Just because I find blue nodes or radioactive nodes with the assistance of it's like a handheld Geiger counter, it's called a gamma probe. Just because I find those nodes doesn't mean there's any tumor in them. It just means that if the tumor would have spread, that's the freeway that it would take. Those are the nodes at risk. So it's a really nice way of identifying the first nodes that would drain the tumor and sending those to the lab instead of having to remove every single node in the basin. And as you can see, you can kind of tell from these photos, it's a very small incision. I make my incisions about this big. So in contrast to big lymph node dissections where the scars are very large, this is a minimally invasive way to stage the regional basin. So it's really a wonderful advance. Okay, so what do you do if you have a positive sentinel lymph node? And this is an answer that has changed in the last couple of years. So this would make the patient a stage 3, and patients now have the option of complete lymph node dissection versus active nodal surveillance, which is a really wonderful new option for patients, and it's come out of recent study data. And this was MSTL-II, so the follow-up, Dr. Morton's follow-up to his seminal trial and published by one of my mentors, Dr. Mark Ferries, and it described the management of a positive sentinel node and gave patients the option of observation, which we'll discuss what that means, or complete lymph node dissection, and looked at its impact on survival and regional disease control. And again, the reason for this study and the impetus behind this for many patients and surgeons was to try to avoid lymphedema and some of those side effects and complications from the complete node dissection when appropriate. And this was just published in June of 2017, so really recent data. So the trial design basics, this is a little simplified, but there were almost 2,000 patients randomized in this trial, and they received either immediate complete lymph node dissection up front for a positive sentinel node, or they received nodal ultrasounds. And these were pretty aggressive. They were quarterly for the first couple of years, and we'll go into that observation scheme. So they were frequent exams and ultrasounds. So the patients that had concerning findings on an ultrasound, lymph node with a cortical thickness of greater than 3 millimeters, loss of a fatty hilum or normal looking blood vessels in the lymph nodes, they had a delayed complete node dissection. So we talked a little bit about what that observation means, which is really important when thinking about if you would be a candidate for this non-operative management scheme, at least up front. And it requires a clinical exam, a physical exam, as well as a nodal ultrasound exam every 4 months during the first 2 years and annually thereafter. So this was the follow-up regimen on MSTL-II. There was another German trial, DCOG-SLT, that had similar findings, and they also had a pretty aggressive follow-up scheme. So this is, it's not for the faint of heart. You're going to be coming into the doctor's office pretty frequently if you opt not to have surgery. But here we can see the graph for the final trial results, and this is looking at melanoma-specific survival, and the lines are right next to one another, and that's the scientist's way of saying that there was no difference between survival in patients that either were observed in red or dissected in blue. So no survival difference, no difference in how long patients live, which is pretty consistent with a lot of the other data we have from other tumor types looking at survival and removal of lymph nodes. It was important, though, to note that the disease-free and recurrence-free survival and regional disease control was improved in patients who received the node dissection. And that has to be sussed out a little bit more. But patients were less likely to lose control of the regional nodal basin if they were dissected up front, but it didn't impact their survival. So that's a nuanced point to the study. Also important to note, and this is probably too small for you to read, but I'll summarize it. This just is looking at the size of the melanoma deposits in the lymph nodes in this study. So as an important note, patients who qualify for this observation scheme typically should have a very small amount of melanoma in their lymph nodes, at least that's what I would recommend, because the majority of patients in this study had a small amount of melanoma in their lymph node. So we can really only extrapolate these data to patients with micrometastatic nodal disease. So what is MSTL-II, or what is this new study that was published in 2017? What does it mean to a patient with a positive sentinel node? The main thing is that the finding of a positive sentinel lymph node requires a discussion with your melanoma team, especially your melanoma surgeon. It requires an understanding of the potential complications from complete lymph node dissection, which can include lymphedema, which can be permanent and disfiguring. We here at Kaiser Permanente have physical therapists who patients meet with both pre and post-operatively to discuss lymphedema and physical therapy and what that would look like for them. But it is something that it has to be discussed, right? Whatever center where you're accessing care. And the decision between nodal basin observation and complete lymph node dissection is a personal one based on your own risk tolerance and your own goals. I always tell patients who can't do the quarterly follow-up, who have either demanding work schedules or might be concerned about losing their insurance or changing providers, it might not be the best option for them. But again, it's a personal decision and requires discussion of the findings on your pathology report. And the melanoma surgeons and the regional team here at Kaiser Permanente have these discussions frequently, both in our regional group, and I have them in the clinic, every day almost. And really, we look at your individual situation and help to make that decision. So I'd like to thank you all for your attention, and we'll take questions following all of this. Thank you.